really want to talk about rotator cuff and instability. And I think there's a little bit of difference, mainly whether or not the rotator cuff's involved. There's a little bit different way we want to work rotator cuff rehabilitation as opposed to instability. Remember, the whole reason you're doing rehabilitation is to restore function. And I'm sure everybody in the room knows, but basically what you do with your surgical procedure does not restore function. It restores anatomy. And anatomy is different than function in a large number of cases, especially around the shoulder. So you need this extra physiological and biomechanical restoration before you're going to get the function that the patient is there in your office wanting you to restore. Function requires optimized anatomy and requires physiology, flexibility, strength, balance, all these things we were talking about, and it requires mechanics, the movements that you have to have. So you have to have all of those things. And any rehabilitation situation you're talking about, whether it's non-operative, post-operative, post-traumatic, involves some elements either because of the injury itself or the problem or the result of what you did to them, has all three of these elements together. Functional restoration requires optimized anatomy, and then you need to talk about task specific. We talk about all this thing about swimmers and workers and everything. Remember, they do have certain different tasks that they're going to have to do. So you need to make sure that when you rehabilitate them, that you take these tasks into consideration. Sometimes it's flexibility, sometimes it's strength, sometimes it's stability, all of these different things that you need to understand. So specific, task-specific physiology and task and activity-specific biomechanics and motions. What you want for a football player may not be what you want for a tennis player, may not be what you want for a worker, so it may be a little bit different in what your expectations are. And then you have to have specific criteria for return to play, because remember, what they want is return to function, return to play, not that you, oh, I fixed that because it looks good on my scope. No, they want to know how they can work or play. So what do you use information as a basis for rehabilitation? I fixed it, and I put a scope in there, and therefore I'm done with it? No, you need more of that. First of all, what is the security of your repair? Obviously, it's different. For labrums, instabilities, you need to know about where the anchors are, what you did with them. For example, in labral surgery, you want to make sure that you've done what you're supposed to do with the biceps. So it's not a peel back. Make sure that you didn't incarcerate it so that you can't get the rotation. A lot of times those 12 o'clock sutures or anchors will create an incarceration of the biceps so that you cannot get external rotation no matter how hard you try. Capsular tension. Did you make sure that the posterior band and inferior glenohumeral ligament was really what it's supposed to be in your labral surgery or your instability surgery? Did you get this circle back together as Buddy was talking about? So, for example, you want to make sure that you're going to fix everything so that you get everything back to where it's supposed to go. So if you have this labral tear, you reattach it down there and you say, okay, this is a stable situation that we can move at the optimum pace. If there's something less than this, then you maybe have to slow it down a little bit. For rotator cuff, type of tendon repair, single row, double row, revision, etc. How good was your attachment? That's a subjective thing right now. I think we're still thinking about what are the criteria for whether or not you have a good footprint repair. You know at the time of your surgery whether you have much tension on your repair. That's going to maybe slow down or change how you're going to do your rehabilitation. And what did you get on rotation? Did you have some stiffness to start off with? Do you need to worry about this, or are you going to try to move a little bit faster? For example, here you got your double whammy here with your labral injury and your in-substance rotator cuff. If you repaired it back, put it back where it's supposed to go, so it's in pretty good shape right there, then you can move it fairly rapidly. But there still is a rotator cuff component that you may not want to move quite as fast as if there was not a rotator cuff component, because rotator cuffs do take longer to heal. What's the associated pathology you have to deal with? Locally, not only was there a labral injury or something like that, but remember the internal rotation deficits, other inflexibilities of the pectoralis minor, of the scalenes, of the biceps, a lot of things that you need to pick up on your exam before you do surgery so that you know that you're going to have to deal with them post-operatively. And then whatever, as I say, that you had some rotator cuff weakness in your labral repair, you need to know that you have to rehabilitate that. And don't forget that every person who comes to you has some component, major or minor, of distant issues that you need to rehabilitate to get back to normal. If you look at failed labral surgery, and you ask the patients really why are they not able to do their function, a lot of them will not be because the same internal derangement they had pre-op, this popping, clicking, pain, and external rotation, they don't have that anymore. What they have is inability to generate force and strength, and that's as much a kinetic chain issue as it is a intra-articular glenohumeral issue, that if you don't address those, they'll never get that capability again. So you need to assess the kinetic chain, the core stability, the scapular control. Okay, what are you going to do about immobilizing it in position? And in our treatment regimen, it's plus or minus rotator cuff repair. So you have to protect the rotator cuff repair longer. And we know from lots of studies that the rotator cuff will not heal very well, very quickly. So if you try to load the rotator cuff repair, whether it be stretching, whether it be isolated activities or whatever, you're going to fail. That does not mean you should not do rehabilitation, but it means you have to protect the repair. Kevin Wilk and I talk this over and over again, and we say, look, it's not slow rehabilitation, it's protected rehabilitation is what you want. And if you don't have a rotator cuff to worry about too much, then you have to protect the labral repair. What's that mean? Well, that's a little less time. You can be a little bit more mobile. You still have to be careful about as much external rotation at 90 degrees for probably 3 or 4 weeks, but you can move them down a little bit faster. So in what we call the negative rotator cuffs, that's mainly the labrals and the instabilities, we protect it for 3 or 4 weeks with minimum biceps eccentric load, because the biceps is what you've usually fixed with your labrum. No external rotation strain, which means you're careful about how much, for example, they say, well, this is passive motion. Take your wand and do this. Well, that's a lot of strain on the biceps. So you be careful about the biceps being eccentrically loaded. We stay below 90 degrees. We do all closed chain activation. You can do anything you want to closed chain that you can do open chain. By closed chain, I mean that you've got your hand supported on something and you move your body around your arm rather than moving your arm around your body. Codman exercises. You do Codman exercises by placing the hand on something and moving the body. You don't have to do this right here. This right here is double the amount of strain on the rotator cuff and joint than this is right here. So just a nice, safe way. So do all your early rehabilitation closed chain. We use a sling 7 to 10 days in these patients, and that's it. After that, they're gone. And our plus rotator cuff repairs, if you look, most of the data about the length of time and the healing is all animal models, so we're having to extrapolate that. But it appears that at least 6 or 8 weeks you have to protect the rotator cuff from any type of tensile load if you want to get this to heal the best. There's also pretty good data that shows no early CPM or this passive motion where you let it hang down or do wand type exercises because that puts a tensile load on the rotator cuff. And most of the literature now will state that no active or active assisted motion away from the body for at least 3 or 4 weeks. Does that mean you just have them sit in a sling and watch TV? No. You got a lot of work you still have to do in terms of the core and the scapula and some humeral head depression, co-contraction close to the body, but that means you're not out here in any way. Low level at 6 to 8 weeks, you do low level of controlled force, and how you control the force is by closed chain and moving your body around your arm rather than moving your arm around your body. Keep below 90 degrees for 3 weeks, no resisted internal external rotation. You can do some passive things by 3 or 4 weeks, but certainly it's no resisted where you're putting a load on this even down at your side. And no active rotator cuff activation, such as any type of open chain for at least 6 weeks. Now we do a lot of, between 4 and 6 weeks, we'll put the arm out, maybe 60 degrees of abduction. We do humeral head depressions, something like this right here, and that's activating a little bit. That's about 20% maximum muscle activation, and that's safe at 6 weeks. It appears that the data appears at 6 weeks is okay to do those kind of things. We do use a sling in this situation for a little longer, maybe 2 to 3 weeks, but we're doing scapular retractions, and we're keeping and letting it come out so that they don't get elbow stiffness. But we really want to eliminate inadvertent motion or use for a couple of weeks. But once again, we're not using a sling for 6 weeks. We find that if you keep the arm in the sling for 6 weeks and you do some EMG testing of serratus and low trap, you find that they go away to nothing. So you're losing a lot of stuff you don't need to lose if you keep your arm in a sling for a long period of time. Now, closed chain versus open chain, you always get this debate, but I think you have to realize that the shoulder, in terms of its stability and the way its muscles work, is a closed chain. Closed chain meaning that there's force couples, co-activation. It's a stabilizing situation rather than a force-generating situation. So if you want to restore the function, then you want to restore this closed chain capability. And so early on, especially, there are a lot of reasons to do closed chain. It's a closed chain mechanism and function. Doing it in a closed chain fashion gets your early restoration of the normal mechanics of this humeral head compression, this concavity compression, which allows the most efficient motion. And then you can do these closed chain, for example, when you're standing, you do some trunk extension, scapular retraction, then you're doing the same activation that is what is the normal pattern for you to use when you're using your arm even overhead. You protect the healing tissue because you put no distal eccentric load. Every time you get your arm away from your body, gravity is eccentrically loading your rotator cuff. If you stabilize it here, then you eliminate gravity. That's why, for example, pool therapy is very effective. And it's interesting that the activation EMG signals from pool therapy versus closed chain therapy, almost exactly the same numbers. So if you have access to a pool at 6 weeks, that's great. If you don't, then closed chain works just as effectively in terms of allowing activation, co-activation with relatively low loads and low activation of the rotator cuff. So it's a pretty good way to do. But the main thing is you don't want a distal eccentric load. It's a low load muscle activation. It's like, say, 20 to 30% of activation, a safe way of moving it. And you get this co-contraction because here you're pushing down, you're making the infraspinatus, you're working the deltoid and the rotator cuff as a force couple, you're working the rotator cuff off a stabilized scapula, once again as a nice force couple. And you get this proprioception, you get this feedback, which once again is very important, especially in your instability and your labral repairs. At some point in time, you need to do open chain, which is by definition moving the arm around with or without a load so that your hand is free in space. You obviously, that's the only way you're going to get full range of motion, and this integrates the maximum force development from your legs to your hand by moving your arm in the way it's supposed to go. You obviously want to, that's the only way you're going to get your proximal stability for your distal mobility, and then you get this strength through the full range of motion. I'm a big advocate in young throwers of the long toss program as a method for building maximal shoulder functional strength. You don't need bench press muscles to throw a baseball. You need this capability of doing the shoulder motion to the full range of motion. So this long toss program is a very good way in throwers, in young throwers, to get this back. Old tennis players like me, long toss program does not work. We need to actually work on strengthening to maximize our capability of hitting the serve. So in the younger athletes, long toss works well. Your older athletes, with your rotator cuffs or whatever, you need to do some strengthening in addition to the long toss program. But it's a very good way of developing strength. And then obviously you have to do plyometrics as the final step on this, because that's how you develop maximum power. That's that stretch shortening type cycle. Okay, so how do you put this all together? What's the content? What's the rehabilitation progressions and return to play? You need to guide this, because you're the only person who knows what's going on in surgery. And you know when you examine them exactly when they're ready to go this next stage, which means you don't do an evaluate and treat prescription. You need to know when it's ready to go from this kinetic chain control situation to a little bit more stabilizing out through here, to doing overhead, to doing the long toss. So there are phases here. One's the first stage is a very large phase, and it's basically the healing phase of whatever, whether it's a tendonitis, whether it's a tear, whether it's a labral, whatever. It's a very broad phase. It's relatively short based on how you treat it. If you fix it, then you let the anatomy heal. The relatively long second stage, which is the recovery stage, this is the physiology stage. This is where you're working on strength and flexibility and balance and integrating the kinetic chain into the shoulder and the scapula. And then the third stage is a very focused functional stage, which is really working more on motions and mechanics. If you kind of break it down this way, this is an understandable way of putting it together. First stage is fixing it. Second stage is getting the muscles to work. Third stage is getting the task-specific activities. So you want to protect the repair, do all your kinetic change. There's absolutely no reason that a person in a sling should not be doing trunk and hip extension, walking, standing, functional things, getting their shoulder blade back. There's absolutely no reason they cannot be doing that. And you get all this back core strength, integrate your core to scapula, make them stand up. We tell them all of our exercises would be standing up or on a balance ball where they have to use their trunk as a core mechanism. Even in the sling, you can be doing scapular retractions like this to minimize the atrophy, disuse atrophy of everything else. There's a whole bunch of exercises we can do here. This is just one that we like. It's called the lunge matrix. You just stand forward, come up, and see what you're doing there. For example, you have this arm in a sling. They can be doing this with arm in a sling. It's just different positions. You see they always come back to the same position of trunk extension, scapular retraction. They go side to side. And this is very effective in your laborals and instabilities very early. You can get that going pretty quickly. Criteria for progression. Okay, they have to be able to control their body over their hip. So just have them stand in one position. Stand on one leg. They got to be able to do this. Got to be able to do this. Okay. Just no cue. Just tell them, because that means that they have. That's a very good screening test for core stability, which means therefore they're ready to. That's their balance point, so they can move on above that. Active scapular retraction. They're not sitting over this way. They're actually pulling back. They can get that scapula retracted where it's supposed to be. Recovery phase, here's where your kinetic change is so important. You've got to normalize it, all your core stability. You've got to have control of the scapula so that you have complete. This is usually in the laborals by about 3 weeks. We start working on this. In rotator cuffs, it's about 6 to 8 weeks. And you integrate the core and scapula to make sure that they do these patterns where they come in, I'll show you in diagonals. So now we're doing our lunges, we're doing our core work, and we're adding scapular retraction. And then you go sideways and do rotations off of that. So you're activating the scapula as you're doing your lunging type exercises. This is our workhorse exercise called the low row. It's a combined trunk extension, scapular retraction, shoulder extension. And you see how the activation, see where the scapula goes. It goes as very nice right through there. So we get a very good retraction. An inferior glide, stay below 90 degrees. Once again, you push straight back and down. Very good. You have to have some healing of your rotator cuff, obviously, but if you've got labral repair, you can do that within 3 or 4 weeks. And pull straight back down. This is called a robbery. It's a bilateral exercise, and there's 2 versions. One's a 38 special, where you're here, and 44 magnum, which are up here like that. So the idea is to get a bilateral activation. And once again, you end up, and this is our lawnmower, a very effective exercise. See, now you're getting core, trunk, and scapula and arm, and you can start any position here and go to any position here, and in your throwers, you eventually want to end up back in this position, back this way as well. And this is a very, it's a very dynamic, very controlled exercise that is the most effective of our exercises. Recovery phase, you got to get motion back. You got to you do closed chain if you want to, body around a stable arm, commons on a ball, then you get up to 90 degrees. So this is how we do our Codman exercises. That way, or if they're real early and stiff, then we'll just put the ball and have them move their body around it. By this time, you're out at 6 or 8 weeks for your labral, 10 to 12 weeks for your rotator cuffs. and you can start loading it more vigorously in safe ranges of motion depending on what your criteria were. And in the scapular plane, put it in the scapular plane. That's the minimal load. Now you got the maximum coconut. Don't put them out in front or out to the side. Put them in the scapular plane. Have them start loading the arm in this plane right here, and you have the most effective activation. We do what's called wall washes and slides, where you once again use your hand on the wall and you're coming down and up, pushing up and rotating at the same time, driving the rotator cuff off of your legs and your trunk. And in the literature, we published several years ago that you go from horizontal to vertical to diagonal, and that puts an increasingly larger load on the rotator cuff. Horizontal is about 10 to horizontal closed chain is about 10 to 15%. A vertical open chain at a fast speed is about 35% maximal muscle activation. So once again, it's a nice progression that you can do that's safe. And once again, they're going to like you a lot better because they're not, every time they go to therapy, they're not hurting real bad and cussing you out because you made them go. And kinetic chain has to be entirely normal. That's when you get your plyometrics. And you want full range of motion, and if you're talking about labral injuries, you want internal rotation between 20 degrees on the other side. And your rotator cuff strength has to be off a stabilized scapula. If you want to really know what your rotator cuff strength is, stabilize your scapula, and then you can really have a good estimation. This is a very effective exercise for throwers. So it's integrating every single thing that the body has to do. On that one leg, external rotation, scapular traction, hip stabilization, core stability. And then you get into your task-specific activities, which would be throwing, working, whatever you have to do with your arms. Our return to play criteria is that you have to have normal core stability as estimated by the one-leg stability series, core strength by sit-ups and push-ups, mechanics that you know that as you watch them. In our office, we got what's called our big room. We can throw and kick into a big cargo net. We have them do the motion and make sure that they can do the right motion. Scapular control, multiplanar. It has to be retract. You have to be capable of retracting as you move your arm overhead. If you cannot retract your scapula, then whatever you did in your rotator cuff or your instability is going to fail. It won't work, and you'll have decreased function. Shoulder exam, obviously, you know how to do a shoulder exam. You know what it looks for, motion, stability, that obviously has to be normal. But you see, that's the end of your criteria for return to play, not the only thing that makes a difference. Okay, so what are the outcomes using this approach? Well, we have a study going on, and we compare it to the literature. We've got 136 patients that involve either labral repairs, rotator cuff repairs, or combined repairs. And we have 173 other patients who have other types of pathology. We're following them. We want to see if this makes a difference early on. We looked at shoulder and elbow scores and active flexion, and we looked in the first 12 weeks. So our data shows that there's our initial score when their first time coming into rehabilitation, which would be usually about a week after surgery. And you see that the scores are about where you expect, down around the 40s. In the first 2 weeks we're there, which is statistically significantly different from that group. And 6 weeks we're there, once again statistically significant. And at 6 weeks, once again, so you see we have a very nice progression in terms of scores for all three groups of patients. Rotator cuffs are a little bit behind, which is what you'd expect because we're not moving them quite as rapidly. But this combined group, which is always supposed to be the bad group, you don't do a labral repair and a rotator cuff in the same patient, they're actually doing better than the individual groups. And then they level off, and at 12 weeks you can see that their scores are between 70 and 80, which is getting close to the good, to the excellent category. If you look at the ranges of motion, once again you see that the rotator cuffs lag behind, mainly because of the design of our therapy program, but you can see that they all catch up. So about 12 weeks, see we got 140 degrees of forward flexion early on doing this program. Now, we've started doing a few follow-ups at a year, and we find that, you know, we have not disrupted the repairs much, and they still have pretty good functions. And once again, you see there's statistically significant improvement early on. Workers' comp doesn't do as well. Yeah. And you see that once again they start with lower forward flexion. They end up doing pretty well, but they're slower through there. So the literature, if you look at the literature at 24 months, you find that their pre-ASES scores were 46 and ours were 40. Their post-AAS is at 82 and ours is between 75 and 80. So you see that what we're getting the first 12 weeks is durable out and comparable to what you're getting at 24 months without any deterioration. So it looks like that those are the things that we want to see. So there's a lot of controversy about, I'm sure some of you all do different than what I do. And it's mainly because we don't have enough basic science to understand this entirely. But this is based on mechanics and physiology, how we put together our program. And right now it's based on these kinetic chain guidelines, and the measurements show improvement and good end results at this early period of time that appear to be durable out over a couple of years. We still don't have the exact criteria for return to play, but once again, it's based on on kinetic chain. So this is where we are right now with our therapy. You can move it, you don't have to limit them, but you have to be careful and you protect the rotator cuff. You don't let the whole body just go to pot in the first 12 weeks. Thank you very much.